I'm Kimberly C. Paul. As I travel throughout each state, I realize that death is just a moment. It is how we live until that moment that matters. Finding connection with friends, family, and complete strangers. Journey with me. This is the Live Well, Die Well Tour. I'm very happy to bring Tracy and Michelle on the show today. We were at a conference yesterday that the Connecticut Association for Healthcare at Home put on for their state. It was awesome. Tracy, how do you think the conference went yesterday?
I was so pleased with it, Kimberly. This is our annual statewide hospice and palliative care summit. And we invite our hospice providers throughout Connecticut, as well as our palliative care providers, which many of them are from the hospital settings. We had over 150 people, including many really unique exhibitors, such as yourself. And we spent the day exploring ways to improve serious illness care in Connecticut. Something that many people may not know is that Connecticut ranks as one of the lowest states in the country in length of stay on hospice. We seem to refer people to hospice very last minute, and it ends up causing quite a bit of confusion with our consumers of such services. So what we did was try to find ways that we could improve on getting people services earlier in their serious illness so that they would be more aware of the choices available to them at end of life and perhaps consider hospice as a better choice than some others that are out there. So thank you.
Absolutely. Yeah, I was really thrilled. I was really captivated by the speakers and what they brought to the table. And so let's talk a little bit, Tracy. Tell me, and I welcome to the show too, Michelle. I don't want to we have two people on the air today with us during the podcast. So Michelle is the chair of the Hospice and Palliative Committee under the board when it comes to the Connecticut Association for Healthcare at Home. But first, before we get to Michelle, Tracy, tell me exactly about what your role is and where do you see that expanding and how do you see it has changed over the years? Because it's not easy to work in hospice care right now.
No, it's not. In any type of home-based services, it's very difficult. So my name is Tracys Role, and I am an RN by training, and I am the Vice President of Clinical and Regulatory Services for the Connecticut Association for Healthcare at Home. We are a member organization that focuses all of our support on the home health and the hospice providers in Connecticut. I've been in this role for 9.5 years, and prior to that, I was in clinical operations for one of the largest providers of home health and hospice in the state of Connecticut, and I was in that role for about 10 years prior. And so I've brought to this position quite a bit of information regarding my role is focusing on supporting our members for all of their clinical and regulatory needs, which, as you mentioned, can be very daunting in this day and age. The federal government and the state government continue to change regulatory requirements, continue to change the scrutiny with which they look at providers and how they give care, ensuring that they're using the government's dollars appropriately. So I'm here to really try to slice and dice all of that information so that our members know how to proceed with good quality, safe, and compliant care. And I have to say that the uptick of scrutiny by the government has really probably supported my role more than anything in the last 5 years. I can definitely see the calls that come in, how needed a person such as the role that I fill is. So it's been very effective, I think, for our providers in the state.
Well, I do know, when I worked within a hospice, we had a quality person. They always counted on their state organization and they called them because you guys have like a broader view and are working with the state, as well as helping every hospice organization, home health organization with you, to make sure that we are compliant. Because when that reimbursement is not coming in, it's a game changer for sure. So I know you're a busy woman. I'm sure you're doing the job of maybe 3 or 4 people these days. And and then you were in charge of the conference yesterday.
Yes, it's probably one of my favorite days of the year. Don't tell anyone, but I'm responsible for both the home health and the hospice providers and supporting them through education and advocacy. But my heart really lies with care of the end of life and trying to help families experience life and death in a very positive way. So yesterday is every year. Yesterday is the conference that I truly love putting on and seeing it come to fruition. And then the day of, I'm on cloud 9 most of the time. And yesterday was.
Yeah, you could tell you drip the passion, and you can really feel the love that you have for those who are serving patients and families. And the one question before we get started and go over to Michelle, are you seeing more and more patients die on home health or in home care services versus hospice lately?
Outside of the hospice benefit, I have to say, we get our annual data from a national company, and the percentage of, we look mainly at our Medicare beneficiaries, those that are over 65, and the percentage of Medicare beneficiaries who access hospice care continues to rise.
Oh, good.
And so we're really right about at the national average right now. Connecticut is right about the national average, which is almost 47% of Medicare beneficiaries utilize the hospice benefit when they have passed away. So we're seeing an uptick of it.
Good.
But 48%, 47%, that's good, but I know we could do much better. So I know that there are many of our home health providers who also try to have a palliative care program so that they can transition people over to hospice a little bit sooner. And, as we get into this conversation today, it might be a good opportunity to really talk about the differences between palliative care and hospice, because I think our communities and our physicians and many nurses don't understand at all what the differences are. So, I think it's important to make sure that we're getting people over into hospice, but our numbers are, I'm rambling now, I'm sorry.
That's okay.
You can edit that one out. I think that our numbers continue to grow, but we have a lot of opportunity to continue to improve further.
Well, I do. I believe that. And, we throw around words like length of stay, and I know that some of my listeners, are caregivers and people going through treatment and are artists. And length of stay is basically when someone comes on to the hospice benefit or into hospice and how long they stay. And what the crazy thing is the hospice benefit is there's a lot of upfront cost and a lot of end cost, because you're transitioning someone onto hospice and then you're transitioning them onto death, which might need, higher pain medications. And so that the in between is where really good hospices can break even and take care of individuals facing end of life. And when they're back to back in the short length of stay, if they only stay, 7 days, there's not a lot of time to recoup that cost. But let's talk a little bit about, just the effects of the families are not better prepared, and the patient possibly with pain management. There's just so many things. And that's where I really encourage people to get hospice early. You will definitely benefit from the care. These people that I met yesterday in Connecticut, they are in it because of the patients and families, and they want to connect and know you guys and care for you guys and journey with you guys, which is some of these people just, some of them are really scored on my heart for sure. Thanks for, and we'll definitely get into kind of hospice and what's the difference between hospice and palliative. I think sometimes the community both sees them as both equaling death, and even though that's part of it, it's not all of it. And I say this: hospice has nothing to do with death. We have a lot to do with living, and palliative is different but somewhat the same. So I do think we need to come back and really dive into what's the difference between those two. So Michelle, you are part of this organization in an advisory board of the Hospice and Palliative Care Committee. What are what's your role? And tell me about how are you advising the board of the Connecticut Association for Healthcare at Home when it comes to hospice and palliative care?
Hi, Kimberly. Thank you. Thank you for having me on for this discussion. So my name is Michelle Codiana, and as a provider member, I am of the association. I serve on both the board of directors and I chair the Hospice and Palliative Care Committee. So that affords me the opportunity to work with industry leaders on our committee, and we're really passionate about bringing forth issues from a regulatory, reimbursement, and policy standpoint that affect hospice and how we deliver care. So as we're able to have those conversations at the committee level, I can then serve to bring that information back to the board of directors to keep them informed, to keep our group informed about some of the challenges and opportunities that we face here in our industry.
Wow. That's a big responsibility. That's a big field too. And it's so really cool to hear that this organization has a committee just focused on hospice and palliative too. What do you see some of the challenges for hospice and palliative in the future? What do you have anything that's coming up that needs to be focused on?
Sure. So I think that always a focus of ours is really breaking down the stereotypes, the misconceptions and barriers to end-of-life care choices for patients and families that impact quality of life. And that can be from anywhere from having conversations about end-of-life care up through the regulatory environment that really drives how we're able to deliver care to the beneficiaries. And so, on the horizon are, the hospice benefit and how that may evolve over time, how palliative care and palliative care being served out in the community can be a collaborative environment for us so that we can continue to evolve in how we're able to spread the message on the care that we can deliver through the hospice benefit.
That's great. And Tracy, why don't we use this time right now to, what is the difference between hospice and palliative care in your opinion?
So I think a couple of things. One thing that I want to call out as I'm explaining this is that our committee that Michelle is the chair of in the last several years has worked really hard in defining palliative care and hospice. And we have a flyer that's available to the public on our website, cthealthcareathome.org, that talks specifically about the similarities and the differences between palliative care and hospice so that we can help the public as well as the providers understand it a little bit better. So palliative care and hospice care are the same in the sense that they are a team approach, a holistic approach to a disease process, really focusing on not just the physical symptom management issues that someone faces with a serious illness, but also looking at the psychosocial, emotional, spiritual assistance that's needed and support. Palliative care really should be given very early on in a serious illness. When somebody, I'll give an example of a cancer patient, when somebody starts with the diagnosis of cancer, whatever type it may be, and the doctor is talking about the treatment plan of giving them chemotherapy and radiation, which we all know comes with significant side effects. And it also comes with a big shock to the person and how they can deal with it and how the family can help them deal with it. Palliative care is that team approach that should be offered then when that serious illness develops, and to help the person and their family know how to cope with it and have quality of life, not just symptom management, but quality of life while they're going through significant treatment. So you're getting the team approach while the person is still being treated for the disease. And then as the person's serious illness advances to a more advanced stage where the person may be going into terminal stages, then it's a good time to get onto hospice. The hospice benefit was created back in 1974, and in Connecticut was the first hospice was established in 1974 at Connecticut Hospice in Branford. But it was established through Medicare as a benefit for the terminally ill who had a prognosis of 6 months or less, as determined by two physicians. So it really takes two physicians to discuss it, look at the symptoms, the trajectory of the illness that person is displaying, and to determine that a prognosis of 6 months or less seems appropriate. Then that person truly qualifies for the full hospice benefit, which again is a team of providers. It would be a nurse, a social worker, the doctor would lead the team. Spiritual counselor, volunteers are really big in hospice to help the family and the patient coping. And then the focus really remains quality of life, but perhaps it's helping the family and the patient understand what to expect as the terminal illness continues on through the expectation that it will be ending soon. And the real value of hospice, beyond being able to care for that patient and family in their final days, weeks, or months, is afterwards when that patient does pass away, there's a bereavement support system in place for 13 months for all of the loved ones involved in that person's that passed away in that person's life. So palliative is very early on in the serious illness, and hospice should be for 6 months prognosis or less. And it also comes with a bereavement support period for 13 months after the death of the person. I think what's happened in the United States, and very specifically in Connecticut with our short length of stay, is that hospice is referred so late in the illness that I call it last minute hospice referral many times, that our communities look at hospice almost as the definition of imminent death. Oh, you're putting me on hospice, I'm going to die tomorrow. Versus sometimes the doctor may institute or introduce, I should say, palliative care when he really should be introducing hospice. And so the community gets very confused. They think palliative care is at end of life when it should be coming much sooner. And then hospice is, okay, now I'm really going.
You know, I will say this. I know, and maybe it's because of my 17 years working in this industry, I want more than 6 months of hospice. Not for only me facing, one day, I'm assuming that I will have a serious illness. It's likely that I want the full benefit that I've paid into. People don't realize that this is a benefit that you've paid into all of your life. And it is such a support for families and patients. And I loved, you had a speaker yesterday, a doctor from New Hampshire, and she really put it into simple language about, hey, when a house is on fire, hospice didn't cause the fire. We're here to help you. And it was really a cool analogy. Tell me her name again.
Her name is Dr. Susanna Makowski, and she is a board-certified hospice and palliative care physician who was trained in San Diego hospice initially, and then came to the Northeast and started working in Massachusetts to build the palliative program at UMass Medical, and then she was recruited up to Exeter, New Hampshire to build their palliative care program. And she's done some phenomenal work. I think some of the things that she really put into perspective yesterday, one thing about palliative care, she said people confuse palliative care and hospice all the time. I'll give you an analogy to help people understand it better. I have a 4-year-old daughter, and sometimes she hurts herself, and I give her boo-boo a kiss. That's palliative care. I'm helping her feel supported and loved and feel that there's someone there with her to go through her pain. That's palliative care. And then the other piece about the fire department, which I found really interesting, she said, here's the analogy that people don't get regarding hospice. They think it is come in and put the fire out at the last minute, stop the fire. And really, the fire department shows up at the house, and you can't stop the fire when it's so late, when it's so out of control. Just like hospice, when you send somebody to hospice so late in the disease process, it's really hard to juggle all the symptoms and what the family is going through. They may not be prepared for the death, just like you're not prepared for a major fire. But if you get the fire department in earlier, you can control it a lot better, just as you can control symptoms, and you can help families cope and deal with the projected loss of a loved one.
Yeah, that was amazing. Now, Michelle, you being on this committee that's, bringing information to the board, you guys, I'm sure, have initiatives, and I would like to talk about some of these initiatives. And I recall that one was to improve earlier conversations, some things about advanced care planning and referrals to palliative care and hospice. I mean, what are some of those initiatives and objectives around that? How are you guys tackling that as an organization to help and support the other hospices in the state of Connecticut?
Sure. So part of our committee work is really, taking a look at, again, what are the, state and federal regulations that are impacting what we do, and how we can partner with statewide groups to really collaborate on a few different things, how we're coordinating care, how we are affording people access to hospice, and then once they're on hospice, how we're also collaborating to ensure that the wishes of the patients and families are being adhered to. So, for example, and actually Tracy works on the committee, and she can speak more to it. There is a collaboration going on where we're working with our EMS providers so that they can be informed as to when patients are on hospice, so that they're getting the appropriate treatment and not aggressive treatment. I don't know, Tracy, if you want to chime in on that.
Yeah, we're actually on several statewide groups, and I think that having the committee as the conduit between the statewide groups and to be able to digest what's going on at the state level so that we can help our providers. So one state group that she mentions is EMS, or Emergency Medical Services. There's a big rise in the country in something called mobile integrated healthcare. And where they're getting involved with hospice providers is many times when a family agrees to put their loved one with their loved one on hospice, some family members may end up panicking at times. In the middle of the night when we're not sure what to do. We remember the hospice told us to do something, but we can't remember right now what we're supposed to do. So their natural reaction is to call 911. Which activates the EMS providers. And so we're trying to partner with those providers to have, the list of hospice providers the list of hospice patients available to them, so if they do call, they can recognize that they're a hospice patient and start talking to them, and at the same time have their dispatch calling the hospice, so that we can try to avoid that person going to the hospital where they really didn't want to go, and try to manage their symptoms. And it's a partnership in trying to engage the community.
I think that's brilliant.
Yeah.
COPD is the worst. When you can't breathe and you can't remember who to call, it is easy 911 that has been installed in all of us since we were young kids. So it's really great that you are partnering, because the the major point we're trying to make right now is that these individuals don't want to go back to the hospital, but sometimes fear paralyzes us and then we are just reactive. And so when the rescue workers, EMS team gets there, they can kind of help with some symptoms or even dispatch the hospice nurse and avoid all of this other unnecessary things that people are trying to stay away from. So I think that's a great idea. That's exciting to hear. Really exciting.
And I think one of the things that is so difficult in Connecticut with us getting our patients on hospice so late is that, you go into the home and you try to meet as many of the family and friends that are part of that person's life as quickly as possible, but you really don't know what the family unit is. Is it strong? Does it have struggles? Are there friends that pop in and out, and some of them are good influences, some of them maybe struggle a little bit with how to manage what's going on. And when you don't get in there early enough to get to know all of those nuances, it's very easy for you to miss a family member that might panic and call 911. So that's all the more important for us to get in as early as possible so that we can help work through some of those family and friend situations to try to help prepare them a little better.
You're right. And I tell you, I tell this a lot, especially on this tour, the Live Well, Die Well tour. I'm sitting around campfires and trying to have these conversations about I want hospice. And, when you talk about, I'm healthy, I know this, and I want to make sure all my providers who take care of me know that. Because you just never know when something happens. Now, can I change my mind? Of course. It's not like just because you've put this in your advanced care planning or directives that those directives can change at any time. Tracey, talk to me a little bit more about some other initiatives that you're trying to address on a state level.
So there's a few things that we've done at the committee level that I think impact the whole state. I think throughout the country, we're very well aware of the opioid crisis. And, hospice providers deal with opioids all the time and trying to manage a person's pain. So what we did, we've seen an uptick in our state of drug diversion, which means, the medications that are in the home sometimes are being diverted by other family members or people coming into the home, or sometimes, unfortunately, even by perhaps one of the hospice providers. You just, you have to really be very careful about trying to protect that person's property, their medications, with the opioid crisis. So what we did was we put together an entire toolkit for our providers that helped them through assessing the risk in the home for drug diversion, putting instructions in place, better safety mechanisms in place for the medications, just trying to identify a higher risk situation versus something else. And then also doing a lot more training with your own staff and oversight to make sure that you've got those checks and balances in place so that you can minimize drug diversion. So that's one big thing that we did. Another big thing that we did, I mentioned the palliative care versus hospice care differences and fact sheet. That's on our website. There's a lot of misunderstanding throughout the country, but again in Connecticut, about the various levels of hospice care. And there are 4 levels of hospice care, which many people don't understand. So we put together a fact sheet on that that's also available for the public on our website. And then 2 years ago, we worked very hard to standardize. We have a mandate by both the federal and the state government to standardize the orientation to hospice philosophy and care that's required in all nursing home settings that offer hospice care. The typical scenario is there could be a skilled nursing facility, a nursing home, and a patient may be in that nursing home and starting to move into the more terminal stages of a disease. And that staff doesn't have their own hospice within the facility, they actually contract with one of our specialty hospice providers in the state to come into their facility and help coordinate the care, oversee the care and the plan with that skilled nursing facility. So we have a requirement to ensure that the skilled nursing facility staff has a baseline level knowledge of the hospice philosophy, the levels of care, different levels of symptom management, the responsibilities of the hospice versus the nursing facility. So we put together an entire training program with a recorded webinar,
Wow.
a test, instructions, so that everybody that provides that level of care in Connecticut can get the same training instead of, one hospice will train this way and another hospice will train this way. Just trying to put some standardization to it. And then the last piece that I just wanted to mention quickly is that we're partnering with our other state healthcare associations, the hospitals and the nursing home associations, on advancing conversations in the community and amongst our provider practitioners. So partnering together on the bigger level, not just at our committee level, trying to really move forward on having conversations earlier in a serious illness.
Wow. So you guys have your hands very full because you have the entire state. But I think I think what you said, number one, is how do we consistently train people to, so it's the same language, it's the same training. So across the entire state, they're getting the same education, which is extremely important. Michelle, tell me a little bit of why was it so important for you to be a part of this organization and play a role, especially with the Hospice and Palliative Care Committee?
So thank you for asking. That's a great question. I think that for me personally, it was really to be part of a group that is really championing for hospice and, allowing us collectively to develop those grassroots strategies for hospice-specific issues, so that we can have a united voice and the ability to influence and impact the future of hospice care for patients and families.
Wow. They're very lucky to have someone like you. And now, Tracey, you did mention in the beginning that you are a membership-based organization. How can someone or an organization, or can one person join your organization? Or is it more of a, who can join this, your organization and be a part of this movement?
So thanks for asking that. Again, on our website, cthealthcareathome.org, there's a members section that has an option to become a member, and we have multiple levels of membership. We have our licensed and certified, that's licensed by the state of Connecticut, certified by Medicare, home health providers and hospice providers. So they're one level of membership. And we have affiliate members, which are the non-licensed providers of home care. You might think of the homemaker companion agencies, private duty companies who, many times people need additional help in their home beyond what the home health and hospice providers can offer on an intermittent basis, but more continuous care at home in order to keep them at home, which is, most of the time that's always the goal. Keep people in their own home because they don't want to, they don't want to leave a place that has meant so much to them over their lifetime. And it also is proven to be the most cost-effective setting for care. So the affiliate membership, it would be that level. And then we have associate memberships, which are predominantly our consultants, legal, accounting, healthcare consultants, HR, all different types of consultants. Yesterday, you saw them as our exhibitors at the conference. We had a pharmacy consultant. We had an essential oils company who worked very closely with some of our hospice providers. Medical supply companies. Those are members. And then we have another level that's called an individual membership. So if you wish to join our association, Kimberly Paul, you can certainly join our association as an individual member. As long as you're not attached to one of the other providers who are already members, then you can join our association as an individual. Many times we'll have people who are, maybe they're in transition between jobs, maybe they've retired and they want to stay connected to the association and make sure that they stay on top of the initiatives. So those would be our individual members.
Oh, wow. And they are all different price based on what you plan to get or receive based on the levels, correct?
Yes, our primary focus based on the dues structure is always for our licensed and certified members, our home health and hospice provider members. We spend most of our time helping them through our networking, education, and legislative advocacy. Not just legislative, but legislative and regulatory advocacy. One of my roles is to act as a liaison between our members and our state regulatory agencies, whether it be the department that runs the Medicaid program or our Department of Public Health that oversees all of our survey processes of our agencies. It also is with our federal level with Medicare and with our regional Medicare offices. And we also do a lot of work with our national organizations. It's a great way to stay on top of things. We're members, our association is a member of the National Association for Home Care and Hospice, also known as NAC, and we're also members of NHPCO, which is the National Hospice and Palliative Care Organization. And I play roles on each of those organizations, various committees and councils to try to make sure that we're as current with the federal information as we can be, so that I can bring that back to our state and ensure that all of our committee level work and our board level work is focusing their priorities appropriately.
That's amazing. And you know what? It is an ever-changing field right now, and it's really important to have organizations like yours supporting those who are actually in the field doing the work. I know for a fact you guys take a lot of stress and burden off these people who are in the homes working with patients and families, and I salute you for that. And also, I just wanted to say to you and Michelle, thank you for your time, but thank you for including me in such a wonderful summit yesterday. It was just an amazing experience to connect with your community of providers, as well as your vendors were so passionate about what you guys are doing. And it was really wonderful to be a part and included in this event. And I really do appreciate what you guys are doing for the state of Connecticut, and keep up the great work.
Thanks, Kimberly.
I'd like to thank you. I did want to say that I also looked quickly at the evaluations, and I have to tell you that you knocked it out of the park with your brief presentation that you offered yesterday. Our attendees absolutely loved your message. It was so passionate, and I know our hospice providers have huge hearts, but the message that you gave just really hit home to them, and they loved you. Thank you.
Well, no,
to echo that, Kimberly, thank you for sharing with us your Live Well, Die Well tour, and for really, you really brought up passion and your advocacy for patients, families, and also for caregivers and the providers. And so, sharing stories and talking about testimonials and really energizing our group, because the work that we do is really hard. And so I think you did an amazing job, and I'm very proud to have had you a part of our conference. And so please continue on with this amazing work. And again, thank you so much.
Well, you're welcome. And I will say this, I do it for people like you. And, I feel all alone out here sometimes going state to state in this crazy tour of mine. But when I come to a conference like this, I walk away inspired to keep doing it, because I still see the faces and hear the stories from everyone in those that shared with me yesterday. And I just am so overwhelmed and grateful just to be included and a part of this movement. And absolutely, I want to enhance services and environments for staff especially, but also with patients and families. And you guys are doing that. And I'm just happy to be included in it. So thank you so much. And if there's anything ever that I can do to support your state, your organization, all you have to do, Tracy, Michelle, you have my cell phone number. Just call me.
Oh, thank you very much, Kimberly. It's been a joy.
Thank you, Kimberly.
All right. Thank you so much for your time today, and keep doing the great work. And I look forward to seeing what Connecticut is going to be doing in the coming years. I'm really happy they have an organization like you. And if you are out there and want to support an organization and you're an individual, go to their website. Tracy, give that to us one more time.
It's www.cthealthcareathome, all one word, cthealthcareathome.org.
And if you're out there also and you are just wanting to donate some money, this state organization does a lot for several hundred, possibly, hospices and palliative care professionals. So it's really important that we, me included, to support these individuals to provide this continued education for their state when it comes to hospice and palliative care. It's a lot of information and a lot of things going on right now. So it's really important that we help take that burden off those people at the bedside. And Tracy, your organization is doing it because you have such great people like Michelle on your board. And I look forward to growing our friendship and hopefully coming back to Connecticut and being with you guys again.
Thank you very much.
Thank you.
Thanks for joining us today. And remember, you're the designer.